Welcome to this educational session on anticoagulation in valvular heart disease. In this presentation, we will review the principles that guide the selection, initiation, and long-term management of antithrombotic therapy in patients with mechanical and bioprosthetic heart valves. Our goal is to simplify guideline recommendations and explain why specific anticoagulants are preferred in different clinical situations. By the end of this session, you should have a clear, practical understanding of how to manage these patients safely and effectively. Valvular heart disease refers to structural or functional damage affecting one or more of the four cardiac valves. This includes stenosis, regurgitation, or a combination of both. When valve dysfunction becomes severe, patients may require surgical or transcatheter valve replacement. Why does this matter for anticoagulation? Because artificial valves, especially mechanical valves, significantly increase the risk of thrombosis. This risk is due to turbulent flow, foreign material exposed to blood, and alterations in normal endothelial function. Understanding the type of valve is the first step in choosing the correct antithrombotic therapy. There are two major categories of prosthetic valves, mechanical and bioprosthetic. Mechanical valves are extremely durable and can last a lifetime. However, their surfaces are highly thrombogenic, meaning clots form easily. For this reason, lifelong anticoagulation with warfarin is mandatory. Bioprosthetic valves, on the other hand, are made from bovine or porcine tissue. They are far less thrombogenic, but they also have a shorter lifespan. Anticoagulation needs differ considerably between these two valve types, and we will examine this in detail in the next slides. For patients with a bioprosthetic aortic valve, the risk of thrombosis is highest in the first 3 months after surgery while the valve is endothelializing. During this early postoperative period, guidelines recommend either low-dose aspirin or warfarin targeting an INR of 2 to 3. After this initial phase, most patients do not require ongoing anticoagulation unless they have another indication, such as atrial fibrillation, venous thromboembolism, left ventricular thrombus, or a hypercoagulable condition. The key point here is that long-term anticoagulation is not inherently required for uncomplicated bioprosthetic aortic valves. Bioprosthetic mitral valves carry a slightly higher thrombotic risk than their aortic counterparts. This is primarily due to lower flow velocities across the mitral valve. Thus, in the first 3 months after surgery, warfarin with an INR goal of 2 to 3 is recommended. After 3 months, if the patient has no additional risk factors, therapy typically transitions to low-dose aspirin. As with the aortic position, long-term anticoagulation becomes necessary only when other comorbid conditions require it. In summary, bioprosthetic valves are associated with a temporary period of increased thrombotic risk. This risk is greatest during the first 1 to 3 months following implantation. Short-term anticoagulation with warfarin is often used, especially for mitral valves, while aspirin is acceptable for many aortic valve patients. After this early postoperative phase, most patients do not require chronic anticoagulation unless they have another compelling indication. This is a critical distinction from mechanical valves, where anticoagulation is lifelong. Mechanical valves are highly thrombogenic because blood continuously contacts non-biological surfaces. For this reason, all patients with mechanical valves require lifelong anticoagulation with warfarin. Direct oral anticoagulants, or DOACs, are not recommended. This is based on clinical evidence showing increased thrombotic and bleeding complications compared with warfarin. Mechanical valves are a classic example where warfarin remains the gold standard therapy. For patients with a mechanical aortic valve, the recommended INR target depends on the valve type and patient characteristics. Most mechanical aortic valves require an INR of 2 to 3. However, patients with additional risk factors such as atrial fibrillation, left ventricular dysfunction, hypercoagulable conditions, or an older generation valve should target a higher INR of 2.5 to 3.5. Low-dose aspirin may also be added in select cases to further reduce thrombotic risk, provided bleeding risk is acceptable. Mechanical mitral valves carry a higher thrombotic risk than mechanical aortic valves due to lower flow velocity across the valve and greater stasis within the left atrium. For this reason, guidelines recommend a target INR of 2.5 to 3.5 for all patients with a mechanical mitral valve. Aspirin may be considered in addition to warfarin in patients with low bleeding risk or in those with a prior thromboembolic event despite adequate anticoagulation. Following mechanical valve surgery, patients are at extremely high risk for valve thrombosis, especially in the first postoperative days. Because warfarin takes several days to achieve therapeutic anticoagulation, bridging therapy with intravenous unfractionated heparin or therapeutic low molecular weight heparin is required until the INR reaches the target range. This bridging strategy ensures continuous protection against thrombus formation during the vulnerable period before warfarin becomes effective. When a patient with a prosthetic valve also has atrial fibrillation, anticoagulation management must address the risks associated with both conditions. In mechanical valves, warfarin already provides the necessary anticoagulation for atrial fibrillation. No additional therapy is required. In bioprosthetic valves, however, atrial fibrillation represents an independent indication for long-term anticoagulation. In these cases, depending on timing after surgery and clinical stability, either warfarin or a DOAC may be used per guideline recommendations. The goal is to tailor therapy to reduce both systemic embolism and valve-related thrombosis while minimizing bleeding risk.